A septate uterus is a congenital malformation in which a fibrous or muscular wall called the septum runs longitudinally through the endometrial cavity, effectively partitioning the uterine space into two separate hemicavities. Imagine the normal uterus as a single, spacious balloon that can comfortably accommodate a developing embryo. In the septate variant, a thin piece of paper called the septum is inserted into the balloon, creating two smaller chambers. This anatomic abnormality is present from birth because it results from incomplete resorption of tissue that normally fuses the two Mullerian ducts during fetal development. The septum may be completely thin, fibrous, or contain smooth muscle fibers, influencing how it interferes with implantation, placentation, and uterine contractility. Clinically, the condition may remain silent or manifest as infertility, recurrent miscarriage, or preterm labor, depending on the size, location, and rigidity of the septum. During the 6th to 10th weeks of embryogenesis, the paired Mullerian ducts normally elongate, approach one another, and undergo a process called canalization, in which the intervening midline tissue dissolves to create a single uterine cavity. In a septate uterus, this resorption is incomplete. The midline septal tissue persists, forming a partition that may be thin or muscular. The defect is purely developmental. It is not caused by infections, hormonal imbalances, or lifestyle factors. Rarely, teratogenic exposures, for example, high-dose retinoic acid, or mutations in genes governing mesenchymal remodeling, such as HOX-A10, WNT4, have been linked to an increased risk, but the majority of cases are idiopathic. Because the anomaly is present at birth, it cannot be prevented after birth, but early recognition is possible through prenatal imaging or neonatal pelvic ultrasound when a family history of Mullerian anomalies exists. The persistent septum creates a physical barrier that alters the normal endometrial environment. A thin, fibrous septum may permit implantation, but often harbors a less vascularized endometrium, leading to poor trophoblastic invasion and early pregnancy loss. A thick muscular septum can significantly reduce the available space for an embryo, cause abnormal uterine peristalsis, and impede proper placental attachment, increasing the risk of miscarriage, preterm labor, or malpresentation. Additionally, the septal surface may produce altered cytokine and prostaglandin profiles that further compromise decidualization. In some cases, the septum extends into the cervical canal, creating a double cervix scenario that can obstruct sperm passage or impede cervical remodeling during labor. Septate uterus is the most frequent congenital uterine malformation, reported in roughly 2 to 3% of all women of reproductive age. Among women with recurrent pregnancy loss, the prevalence rises to 5 to 10%, making it a leading structural cause of infertility and early miscarriage. The anomaly occurs worldwide without ethnic predilection and is equally distributed across socioeconomic groups. Family clustering has been observed, suggesting a modest heritable component, but no specific population-wide risk factors have been identified. Clinical presentation varies widely. The most common red flags are repeated early pregnancy loss, often before 12 weeks, despite otherwise normal fertility workup. Difficulty conceiving, attributable to impaired sperm transport or suboptimal endometrial receptivity. Dysmenorrhea or menorrhagia, which may result from altered uterine contractility and increased surface area of endometrium. An abnormal uterine contour noted on bimanual pelvic examination. A tender midline ridge. Many women are asymptomatic, discovering the septum incidentally on imaging performed for unrelated reasons, such as evaluation of ovarian cysts or routine prenatal scans. First-line evaluation employs a transvaginal 2D ultrasound, which can reveal a linear echogenic structure extending from the uterine fundus toward the internal os. If the septum's length or composition is ambiguous, a 3D ultrasound offers volumetric reconstruction that accurately measures septal thickness and determines if the cavity is partially or completely divided. Magnetic resonance imaging provides superior soft tissue contrast, especially useful when differentiating a septate uterus from a bicornuate uterus, which has an external fundal indentation. Hysterosalpingography demonstrates a narrowed or bifurcated cavity after contrast injection, while hysteroscopy offers direct visual confirmation and the opportunity for immediate operative correction. The diagnostic algorithm typically proceeds from non-invasive imaging to invasive confirmation only when surgical planning is contemplated. Septate uteri are categorized by the extent of septal penetration. Partial short septum, the septal tissue terminates above the internal cervical os, leaving a normal-appearing cervical canal. The residual cavity is usually asymmetric, but retains a single external uterine contour. Complete full septum, the partition continues through the internal os and may extend into the cervical canal, occasionally producing a double cervix. In extreme cases, the septum can reach the vaginal vault. The classification guides therapeutic decisions. A complete septum often requires more extensive hysteroscopic resection to achieve a unified cavity, whereas a short septum may be amenable to conservative trimming. The gold standard therapy is hysteroscopic metroplasty, a minimally invasive outpatient procedure performed under general or regional anesthesia. A resectoscope equipped with a monopolar or bipolar loop is introduced through the cervical canal. The surgeon then incises or vaporizes the septal tissue under direct visual guidance. The goal is to create a single, spacious endometrial cavity without perforating the uterine wall. Operative time averages 15 to 30 minutes, and post-operative recovery is typically uneventful, with most patients resuming normal activities within 2 to 3 days. Adjunctive post-operative care may include a short course of estrogen to promote endometrial regeneration and prophylactic antibiotics to reduce infection risk. Large meta-analyses demonstrate that pregnancy rates rise from approximately 30% pre-surgery to 70 to 80% post-surgery, while miscarriage rates drop to levels comparable with the general population. Because a septate uterus is congenital, primary prevention is impossible. However, secondary prevention, early identification before reproductive complications arise, is achievable. Routine pelvic examinations, especially in adolescents with a family history of Mullerian anomalies, can prompt early ultrasonographic screening. Preconception counseling that includes a detailed obstetric history, for example prior miscarriages, may lead clinicians to order a targeted 3D ultrasound, thereby allowing timely surgical correction before pregnancy attempts. Public health messaging, focused on the importance of early fertility evaluation for women with recurrent loss, can indirectly reduce the burden of untreated septate uteri. Prognosis is excellent once the septum is removed. Post-operative studies report live birth rates of 60 to 80% and a miscarriage rate that approximates that of women with normal uterine anatomy, 10 to 15%. Fertility potential remains intact. Ovarian reserve and tubal patency are unaffected by the hysteroscopic technique. In untreated cases, the likelihood of recurrent miscarriage or preterm delivery stays significantly elevated, 30 to 40% miscarriage, 20 to 30% preterm birth. Long-term follow-up shows low rates of intrauterine adhesions when proper postoperative estrogen therapy and gentle uterine instrumentation are employed. Cutting-edge research focuses on precision imaging and robotic assistance. High-resolution 3D ultrasound combined with virtual reality reconstruction enables surgeons to visualize the exact thickness, length, and curvature of the septum preoperatively, allowing tailored resection plans and reducing operative time. Early pilot studies of robot-assisted hysteroscopic metroplasty report improved ergonomic control, especially for thick, muscular septa, and a modest reduction in intrauterine perforation rates. Additionally, molecular studies are exploring the role of microRNA expression in septal tissue, which may predict healing outcomes after resection. Although promising, these innovations require larger randomized trials before becoming standard of care.